Examining the shoulder joint complex, we would do the same for any other patient. Start with inspection, so looking at how the patient is. Are they in any discomfort? Are they holding themselves in an antalgic manner? Is there any clear bruising, any swelling that we can see, any asymmetry? So we look at the major bony landmarks, which we'll come to, and then looking at the general muscle bulk, see is it symmetrical, any clear wasting, any discrepancy we can see from both sides. We'll do the same with the side profile. Again, particularly looking for any wasting in the muscles, the deltoid region and around the cuff, and the upper trapezius region. Are there any scars? Is there any bruising present? Is there any clear deformity that we can see? Moving on to palpation on the anterior aspect, palpating along the sternum, looking for any pain or discomfort. Feel the sternoclavicular joints. Moving laterally, and feel the acromioclavicular joints bilaterally. You can feel if there's a step, if there's any crepitus or discomfort when palpating. Any clear evidence of a dislocation in the past. Feel the tip of the acromion, looking at the levels to ensure that they're the same on both sides, how the whole patient's holding themselves. Inferiorly, you can palpate the coracoid processes, looking for any pain or discomfort, and then just inferiorly to that, the short-headed biceps. Laterally and inferiorly, again, we can then feel the pec major tendons. Good to have a turn around. Repeat the process on the back. So we'll have a look and see, is there any clear atrophy, particularly around the muscles of the scapula? Are the tips of the acromion held at the same levels? Do the scapula appear symmetrical on both sides? Is the muscle bulk around the same? Is there any bruising, scars again? Any swelling that we can see anywhere too? Following this, we then palpate. So we palpate along the spine of the scapula and the medial border of the scapula, the angle of the scapula. Looking at the position, is it the same on both sides? Is it the same level? Is there any pain or discomfort when palpating? Again, in the supraspinal fossa, feeling for the muscle bulk, ensuring there's no wasting that we can see there. Following this, we then move on to range of movement. So normally start with posteriorly from looking at the scapula. So I'm going to ask you to lift your shoulders up. So looking at the muscle bulk, how both scapula move together. Are they symmetrical? Is there any clear winging here and down all the way? And bring your arms forward, protrude your shoulders forward. Again, listen if there's any winging, if the movement's adequate, but not excessive from both the scapula. And back, bring your shoulders back all the way back. And same again from this position. And I need to have a turn around. Then move on to active range of movement at the glenohumeral joint. So we compare each side. We'll start with one just for time's sake. Looking at forward flexion of the shoulder, so you need to bring your arm out to the front as high as it will go. Looking at the quality of movement, if it brings on any pain, any audible clicking, any discomfort that we can see, and then back down and all the way out to the back. The extension, looking for the same. You can feel over the joint line whilst the patient's doing so to feel for any crepitus or any pain as they are doing so with the musculature. Come back to neutral. Bring your arm out to the side. And back down, looking for the same things. We compare it with the opposite side to ensure it's the same, within the same range of movements, particularly important in athletes. Keeping your elbows, we'll do both for this. Keeping your elbows both tucked in, turn your arms out. You can get equal range of movement. If it brings on any pain or discomfort, and back to neutral. With both your thumbs, can I get you to point them up and touch as high as you can on the back? So now looking at internal range of movement, we can compare the levels that the thumbs get to on both sides as a reference, as well as a comparison between the two. And back to neutral. The arms at 90 degrees. We then look at, from an impingement side of things, looking for the range of movement in internal. So turn your hand down. And external range of movement. Turn your hand up, looking for any pain or discomfort. And relax, we compare to the opposite side, as with any joint. Then looking at passive range of movements, we'll move through, palpating the joint line, feeling for any crepitus, bringing the arm up, for any crepitus, any pain or discomfort that can feel, any clear swellings, any movement within the joints, external rotation, and then extension, and then similarly abduction, feeling for the end feel, and the range of movement, quality of movement. Then feel internal rotation, external rotation, and we can repeat at 90 degrees for the impingement pattern. You then obviously compare the opposite side for looking for symmetrical range of movement, same quality, and as a comparison and as a reference point. And look at the muscle power, push out against me, keep going, all the way, showing the muscle powers as we'd expect, and that it's not eliciting any pain to do so. And bring your arm back down, keep going, and relax, back to neutral, push out for me, keep going, so feeling across the full range of movement. In, bring your arm out for me, push in against me, push out against me, and at 90 degrees, push up against me, push down against me. Once we compare to the opposite side, we're going to move on to the special tests. We normally start with looking at the scapula, so from a wall push up, get you to stand by the wall, hands both facing the wall, and a push up, ensuring they can do this movement, looking at the range of movement of the and ensuring there's no winging of the scapula, suggestive of inadequate power support around the shoulder girdle or in the scapula, as well. Come back and have the perch on the end of the bed, looking at the AC joint. Perform the scarf test. You get to put your hand over the top across your opposite shoulder. You can then increase this by putting some downward pressure, then looking for pain or apprehension usually. When we're looking for bicipital tendinopathy, Jurgensen's test, so with their arm neutral and elbow flexed to 90 degrees, then we'll resist supination, so don't let me move you. And with the arm all the way pronated, don't let me move you, resist supination. You can feel like over the biceps tendon, feeling to see if there's any pain or discomfort as we do that as well. Speeds tests with your arm out like this, push out against me, keep going all the way up, keep going. Again, if you're in the same position, see if there's any pain or discomfort where we're palpating the biceps tendon. When we're trying to evaluate for a slap lesion, Kuhn's test, which is threefold. So one of them is Jurgensen, as we've just discussed. So we're looking for pain with from that. We're also looking to see, so with a inferior sulcus test, the arm at 90 degrees, apply a downwards pressure onto the humerus, looking for any pain or apprehension. Following this, supporting the scapula and the shoulder girdle, and we're applying a downward force, so a distraction, looking for pain or discomfort. That combined with Jurgensen gives us the three-part elements of the Kuhn's test. O'Brien's test is another means of evaluating for a slap lesion. With your arm out to 90 degrees, turn your thumb pointing down, and resist, don't let me move you, resist downward pressure, putting strain on the long-headed biceps as it's pulling at its insertion. We can consider apprehension testing, so passively abducting, externally rotating the shoulder. Of course, we compare to the contralateral side with all these as well, usually looking for apprehension or excess movement as we externally rotate in this position. for impingement, empty can test, bring your arms out to the sides and slide 30 degrees forwards. Thumbs pointing down into a position which is going to compress the rotator cuff. Don't let me move you. Applying a resisted downwards force. Knees test, where we pronate the forearm, palpate over the shoulder girdle and passively flex. Keep in pronation, passively flex the shoulder to full range. And Hawkins Kennedy, another test for impingement. Place my arm across the patient to the opposite shoulder and apply a downward pressure, stressing the rotator cuff in the position of impingement now. Relax. As with any joint, always consider the joint above and below, particularly with the shoulder. You need to consider about referred pain for the neck. Neurovascular assessment of the upper limb is always sensible, looking for any peripheral nerve injury or any radiculopathy